Very good afternoon to all. So we are moving towards our second session of the webinar series based on canine vector-borne disease. So, as you know that in first session you have seen there was the lecture by Dr. M.L. Gatne sir. So when he will start taking the second lecture, he will give you the briefing what exactly was taught in the first session, and then we will go with the second session on canine vector-borne disease that is based on the diagnosis and management. So without wasting the much time, uh, I would like to hand over the session to Dr. M.L. Gatne sir, who is a former professor and university head of veterinary parasitology, Bombay Veterinary College, with lots of achievements, and he's having a very good experience, a great experience, not only with the theoretical but also with the clinical, where our veterinarian colleagues all across the India, they will get a very good benefit of it in terms of knowledge, in terms of his experience. So I would like to hand over the session to Dr. M.L. Gatne sir. Please, sir.
Okay, so good afternoon, friends, and welcome back for the second episode on this canine vector-borne diseases. In the first lecture, we have seen the clinical epidemiology of canine vector-borne diseases, and in that, I think you all will recollect that I had mentioned that these cases are occurring more frequently, and these cases are not straightforward cases, these are complex cases, and that is why up-to-date knowledge is required. And I had mentioned about two different sites. One is a TROCAP and second is CVBD. So in future also, whenever you want any additional information or the recent information, you can very well visit these two sites for the updated knowledge. Then just a recap now, we all know that these vector-borne diseases can be categorized into three types: flea-borne infections, fly-borne infections, and tick-borne infections. Yeah. So, in fly-borne infection, as I have mentioned last time, that trypanosomosis is very important, and we have discussed about epidemiology along with other tick-borne infections. Leishmania is restricted to only one part of India, and the prevalence is also going down. So, we haven't discussed much about leishmanosis. Diarrhea I've already mentioned there are two forms of diarrhea. One is a cardiac form, which is caused by Diarrhea emetis, and the second is Diarrhea repens, which is more prevalent in India, and that is subcutaneous form. The importance of subcutaneous form is that it has got a public health significance. That means when they jump onto human beings, sometimes it may lead to a serious conditions like ophthalmic involvement. Then in tick-borne infection, which is the major portion of CVBD, where we have hepatozoonosis caused by hepatozoon canis, ehrlichiosis caused by Ehrlichia canis, anaplasmosis by Anaplasma platys, two forms of babesiosis. Large form is Babesia vogeli, and the small form is Babesia gibsoni, and then mycoplasmosis also prevalent in India. Then I had discussed about one particular survey which was carried out, and let me tell you that this is by far the largest survey carried out in India till date. And in that, about 525 blood samples were examined, and they were subjected to the conventional method, that is thin blood smear and Buffy coat method, as well as a PCR technique. And the results are there in front of you in the table. And what I emphasized last time was that, the prevalence rate is quite high to the tune of 60 to 75% in most of the parts of India where the climate is either hot and humid climate or dry and arid climate. And there are mixed infections. Every alternate case of CVBD represents mixed infections involving, two, three, or even four different species of organisms. If you look at the prevalence, the highest prevalence was Hepatozoon canis, followed by Ehrlichia canis, Mycoplasma hemocanis, Anaplasma platis in the descending order, then Babesia vogel and Babesia gibsoni. You'll be surprised to know Babesia gibsoni is nil in Mumbai and Delhi, but mind it well that this survey was carried out way back in 2012 and 13. And since then, the epidemiology has undergone a little bit of change. And of late, in last 3-4 years, Babesia gibsoni cases outnumber any other form of CVBD. So these infections are widely prevalent, and we can say on the basis of this data that Hepatozoon canis, Ehrlichia canis, Mycoplasma hemocanis, and Anaplasma platis. And to add to this, of course, I don't have a scientific backing here with me, but you can very well add Babesia gibsoni as the endemic organisms or endemic diseases in different parts of India. Then the multivariate analysis revealed that the possibility of TVBD or CVBD is more in dogs having PCV less than normal, obviously, than in dogs having ticks on the body, in stray dogs. And the most important finding we noticed last time, and that was the chances of vector-borne diseases are more in intact animal as compared to neutered animal. And at that time, I had also mentioned that sometimes, the treatment is not effective. And these cases or the relapses are quite common. And in order to manage such relapses, neutering is also one of the options what we have. Then in the clinical epidemiology, as we all know that we have seen, there are certain telltale signs of a CVBD which are common to all the organisms. And then we have also seen there are certain other signs which may be seen, that is nervous signs, eye lesions, sometimes joint pains. And that time when the organisms, yeah, there's an echo. Okay. So in such cases, what happens, the general, if you look at the symptoms, then you will find that it is indicative of CVBD. But at the same time, looking to the epidemiology, what we know that the multiple infections are common. Nobody is in a position to tell you whether it is a single infection or a multiple infection. And even if it is a single infection, it is very difficult to pinpoint or specify which type of organisms are involved in that particular infection, that we have seen very well in the last lecture. But in that also, we have seen some of the symptoms which occur more frequently, which are of a more magnitude and occur for a prolonged period in certain diseases. So when you come across these symptoms, then the needle of suspicion is diverted towards a one or two different types of diseases. As I've said, that when you see that there are bleeding from the natural orifices, one can think of monocytic ehrlichiosis. Lymphadenopathy and eye lesions are seen in trypanosomosis and ehrlichiosis. Particularly hypothermia, that means the temperature, rectal temperature below the normal, happens when there is intravascular coagulopathy and a hypovolemic shock, and that happens in Babesia gibsoni infection. Nervous signs are predominantly seen in trypanosomosis and also in pyroplasmosis. Edematous swelling of jaw and the lymph nodes of the neck and head region with change in voice, typical feature of canine trypanosomosis. And then we have also seen that in hepatozoonosis, all these signs are there, nothing alarming as such, but a prolonged lethargy, then you can think of hepatozoonosis. As I've said, that mycoplasmosis does occur, but it is more of a complicating organism. Very rarely you will see a pure infection of mycoplasma. Then when the blood samples are collected, because on the basis of clinical sign, it is rather difficult to identify the infection. So one has to go for laboratory investigations, and initial response of a clinician is to collect the blood sample and try to find out hematobiochemical profiles. And in that also the picture is the same, in the sense that all these different organisms cause a similar type of hematobiochemical changes. There is a regenerative kind of anemia, which is normochromic, normocytic, and there is also thrombocytopenia. I recollect we have discussed this, that thrombocytopenia should not be equated with canine monocytic ehrlichiosis, because it also occurs in some of the other canine vector-borne diseases. Of course, the magnitude may differ, and that we have also seen in some of the slides. In biochemical profiles, you will see, and of course, these profiles are seen in chronic cases or in long-standing cases. So where you will find that there is a high serum creatinine, then blood urea nitrogen is also there. I had mentioned about the ratio of serum creatinine to blood urea nitrogen to see whether the cause is a pre-renal cause or a renal cause. And then there is a reversing of albumin and globulin ratio, elevated levels of SGOT and SGPT. As I've said, that thrombocytopenia is seen in different CVBDs, and there are different reasons for thrombocytopenia. And in this table, we have discussed that in the previous lecture, that thrombocytopenia in trypanosomosis, the exact reason is not known. Probably that there is a coating of antigens like on RBCs, on thrombocytes also, or on platelets also, and such platelets are vulnerable for phagocytosis. So that could be the reason. Of course, there is no scientific backing in the literature as such. Then antiplatelet antibodies are formed in prolonged infections, in ehrlichiosis and also in babesiosis. In Babesia gibsoni, as I've said, there is intravascular clotting. And obviously, when you say intravascular clotting or a clotting as such, there is utilization of large number of thrombocytes, and that is the reason of thrombocytopenia. Then there is also injury to the endothelium of the capillaries, and in order to heal that, the thrombocytes are used, so consumptive process is there. Then if there is a liver or a kidney damage, then in such cases also there is thrombocytopenia, for the reason that these are the principal sites where the precursor of thrombopoiesis is formed, and that is thrombopoietin. We have also seen that anemia is basically immune-mediated anemia because of the coating of different types of antigens on the surface of RBCs and probably on thrombocytes. And then, such cells become very, very fragile, and then they are vulnerable for erythrophagocytosis in the spleen. And that is how the lifespan of the RBCs is reduced, and that is the reason of anemia, which is mainly normochromic normocytic. Barring one exception, that is an advanced case of ehrlichiosis, you will find the anemia is normochromic normocytic. In advanced ehrlichiosis, it could be hypochromic microcytic non-regenerative kind of anemia. Then, as I've said, it is basically due to immune-mediated response. And if you do the Coombs test, the Coombs test becomes positive in such cases. Then there are two, in long-standing cases, there are two basic, what should I say, the outcome. One is, hemolysis, and you will find there are symptoms associated with it, that is hypoxia. Then the mucous membranes become pale. Sometimes when the hemolysis is on large scale, then indirect bilirubin increases, and you will also see icteric mucous membranes, exercise intolerance, general malaise, the general condition goes down, and sometimes the dogs, faint, and even the death is there. So that is a hemolytic crisis, which may also be seen in some other conditions, and one has to differentiate it. Then second is, like a systematic inflammatory response or reaction in different organs. As I've said, this is classically seen in Babesia caused by Babesia gibsoni, where certain kinds of cytokines are released on large scale, and those are like a tumor necrosis factor. And when it has got a direct proportion with the symptoms, and in such cases, certain biochemicals that are released as a result of this, like nitric oxide and nitrous oxide, and free radicals of oxygen, and these biochemicals are primarily responsible for mediating a reaction between the infected RBCs and the cell wall, and the vessel wall. And in such cases, then there is a inflammatory reaction. So that is in long-standing cases or in terminal cases. Like symptoms, even in clinical pathology also, there are certain, changes which are suggestive of certain diseases because they occur more frequently, the magnitude is more, and their duration is also there. Like, we have seen in case of aplastic anemia, it is a clear case of canine monocytic ehrlichia because there is thrombocytopenia, there is anemia, and there is also leukocytopenia. Then azotemia or proteinuria you will find basically in trypanosomosis and pyroplasmosis. Thrombocytopenia, yes, ideally in ehrlichiosis, but also in other infections including trypanosomosis. Increase in liver enzymes, you can think of hepatozoonosis. Coagulopathies, as I've said a couple of times, associated with Babesia gibsoni infection or pyroplasmosis. And hypoglycemia, because these trypanosomes, when they are multiplying in the blood, they utilize blood glucose. Not only that, but they also affect gluconeogenesis adversely. That is production of glucose from non-carbohydrate sources. So that is also affected, and as a result of this, there is hypoglycemia in trypanosomes cases. So that was a quick recap what we have dealt with in the previous episode. Now let me take you through the diagnosis and management of canine vector-borne diseases. I am pretty sure you all are looking forward anxiously to this particular part of presentation. So let me start with the diagnosis first. Now, in the diagnosis, there are basically three approaches. One is a conventional approach, second is immunological approach, and third is a molecular approach. Now, in conventional approach, what is conventional approach? Conventional approach means you collect the blood sample, ideally from the peripheral circulation, okay, and then you prepare the blood smear from the peripheral circulation. I would say you should go one step ahead and prepare a buffy coat of the peripheral sample and prepare a buffy coat smear. When there is an enlargement of lymph node, you take a lymph node aspirate and prepare the smear. So all these three come under the conventional method. And when you prepare the smears, mind it well, the smears should be thin smears. So all the cells should be separated very well so that you can inspect each and every cell under the microscope. So then they are stayed with either Leishman, Giemsa, or a field stain, whatever is available. And then the slides are examined under the microscope for detection of the organisms. When the organisms are detected, it is, the obvious witness that the infection is present. Now, there is no doubt when the organisms are detected. These methods are available in most of the part of India. That is the advantage. Then the cost is also not high. It is available within 250 rupees. Okay, and so these are the advantages. Now, what are the disadvantages here? Is that the techniques are not a very sensitive technique. For example, Ehrlichia canis or Babesia gibsoni. Even in heavy infections, you may not detect the organisms in the blood smears or in the buffy coat smears. Okay, so this is not a sensitive method. All cases cannot be caught. That is one. Number two, although it is very simple, you don't need any sophisticated techniques or the equipments. It is a tedious method because, in order to go through a blood smear, it is expected that the technician, pathologist, or a parasitologist should inspect at least 1,000 RBCs, right? So which takes time, because it is also strenuous to your eyes also. You are inspecting the RBCs for the inclusions. Then you are also seeing if there are any extracellular organisms. So it takes time. It is a tedious method. In my professional experience, I'll tell you, I used to take around 15 to 20 minutes to complete one blood smear. So, because my professor also used to tell me that in order to declare that the blood smear is negative for any of the organisms of CVBD, one has to see the blood smear for at least 20 minutes, and then only he or she can declare it as a negative. So it is a time consuming process, and I think nobody can see more than 10 to 15 blood smears in a day on a regular basis. So it is very time consuming, tedious, strenuous for the technician also. Then what should we do? Yeah, before that, these are some of the images as you can see on your screen, right? Like here you can see the morula stages of Ehrlichia in the granulocytes. So these are hepatozoon canis, which are the cigar-shaped organisms you can see in the lymphocyte here. Then here you will see these are the intercellular organisms, and these are trypanosomes. Then here you can see microfilaria. I cannot say whether it is Dirofilaria immitis or a Dirofilaria repens because one has to study it very carefully with the micrometry. Then here you will see these are Babesia vogeli, large pyroplasm. You can see the size here occupying almost, the radius of the RBCs. And then you will see here the mycoplasma. These are, very small organisms, rod shape, or, the cocci, which are sitting on the RBCs. And these are mycoplasma. Here you will see Babesia, uh, Babesia gibsoni organism, which are a small pyroplasm. But let me tell you, that certain organisms are obvious, like hepatozoon canis, you can't miss it. Trypanosoma, you can't miss it. Microfilaria, you can't miss it. But for other organisms, one has to have a good experience. Okay, so a very, very experienced eye is required to detect particularly a small organisms like mycoplasma or Babesia gibsoni. And for a prerequisite for that is, proper staining. The stain should be with a minimum artifacts, because ultimately when you are peeping inside the microscope, there will be artifacts, and it is your job to differentiate, or a job of a pathologist to differentiate whether it is an artifact or the organisms. So experienced eye is required. And so these are the organisms. So in conventional method, what I want you to do in the field conditions, particularly in rural areas or the areas where, sophisticated techniques are not available. As far as the clinical case is concerned, when the dog is showing all symptoms of canine vector-borne diseases, that phase is last around for 5 to 7 days. So during that period, I want you to collect at least 3 peripheral blood samples during the active phase of infection, at least 3 on alternate day. Then take it in a capillary and prepare a buffy coat, and then prepare a buffy coat smear. If you do it for more number of times, that is good. That is going to improve the sensitivity. So those buffy coat smears are prepared. If there is a lymphadenopathy, take a lymph node aspirate smear also, and go through the conventional method of microscopy. And if all the 3 samples or more than that, if all these samples are negative, you can tentatively take it that the animal is negative for trypanosomosis, hepatozoonosis, and mycoplasmosis. Mind it well, it is the active phase of infection I am talking about, not the subclinical cases. And then you are collecting a peripheral blood samples, preparing a buffy coat smear, and in addition to that, if available, lymph node smear or lymph node aspirate smear, stain it properly, and if 3-4 samples during active phase are negative, you can rule out hepatozoonosis, trypanosomosis, and mycoplasmosis. There is a reason for this. In trypanosoma infection, generally dog is a very, very susceptible host. So the multiplication is very fast. And you will see the blood sample is teeming with trypanosomes. I have seen in my career some of the blood smears where the number of trypanosomes were more than the RBCs. I have seen such smears. So you can't miss it. Okay. So trypanosomosis, hepatozoonosis also, if you look at the life cycle pattern of hepatozoonosis, you will find that after entering into the body, the organisms rapidly multiplied in the endothelial cells of different visceral organs. And then after one generation of asexual reproduction, then the gametogonous stages are thrown into the blood and they appear in the WBCs. So within 15 to 20 days, those gametocytes appear in the WBCs. So you can't miss it. The level of parasitemia is usually 1 to 3%. So if you examine the buffy coat smear, where you can examine 100 or 200 leukocytes, you will definitely get hepatozoonosis. Similarly, in trypanosomosis, I forgot to mention one particular feature of trypanosoma infection in canine is that parasitemia coincide with pyrexia. So that is why, they are teeming with the parasites. In mycoplasmosis, I know that one has to have a good, experience with the mycoplasma because they are really tiny organisms. You may find it, like artifacts also. See, there's one thumb rule. If you want to differentiate between an artifact and something that is the inclusion of the cell, you just change the fine adjustment knob. If that particular spot is disappearing with the cell, then it is an inclusion. But if it is disappearing at a different level and the cell is disappearing at a different level, it is on the leukocyte or on the RBC, and that could be artifact. So that is how one can do it. So these three organisms you can rule out if it is negative. If it is positive, obviously you will get it and you will treat it accordingly. So if it is negative, if 3 samples, buffy coat samples are negative, then trypanosoma, hepatozoonosis, and mycoplasmosis, for all practical purposes or field condition, you can rule out. But still, there are organisms like ehrlichiosis, anaplasmosis, babesiosis, and dirophliriosis. So in such cases, you need to have certain other techniques, like immunological technique or a molecular technique. As you all know that in immunological technique, the antibodies against the particular organisms are detected, and there are very few instances where antigens are detected. In molecular technique, the DNA of the organisms are detected. So as far as the conventional, I know that there are certain limitations, but if you use it judiciously, if you use it properly, and particularly by preparing a buffy coat smear and during the active phase of infection, at least for trypanosomosis, hepatozoonosis, and mycoplasmosis, you will get a good clue. Then coming to the immunodiagnosis, that is a second approach. Sorry. So in immunodiagnosis, ideally, I feel that there should be immunology laboratory, which is engaged in doing certain basic techniques like indirect fluorescent antibody techniques or immunoassays. These are two very good techniques for diagnosis of canine vector-borne diseases or even hemoptysis infection. The reason being that in these techniques, IgM class of antibodies are detected, and those are those indicate IgM class of antibodies indicate active infection or the presence of organisms in the body, right? Because those are early antibodies, and that is why these tests are really, really very good. Now, these facilities can be availed only in areas where there are veterinary institutes, like veterinary colleges are there, or veterinary research centers are there. There you can have this kind of facilities. But otherwise, you don't get these facilities. So in such cases, nowadays, as you all know, in the market, there are kits are available. Those are the immunodiagnostic kits by different companies. Now IDEX is there, then Secure is there. So many other companies are there. And then you have a 3DX, 4DX, 4DX plus, depending upon the panel of organisms which are included in that particular kit. So here, uh, it is really a good method in certain situations where there is a spot diagnosis is possible. That means this test or these kits can be used within 15 to 20 minutes, and the technique is also very, very user friendly and very quick to perform. And then it is also very sensitive, right? In most of these kits, ELISA pattern is utilized, and that is why it is very, very sensitive. The thing is that you can also impress upon the owners, the pet owners. You can show them the results of the kits, so you can impress upon them that okay, your dog is infected with A, B, or C different type of organisms. Now, there are certain issues about the specificity. In this case, I don't know how many of you have experienced this, but you get a positive reaction for anaplasma phagocytophilium, the organisms which is not reported from India. So it is a cross reactivity. Ehrlichia canis cross react with anaplasma phagocytophilium. Even anaplasma platis also cross reacts with that. Why that? In Dirofilaria, heartworm also, this is the test which detects the antigen. It is not antibody detection in Dirofilaria. Antigen of a female worm is detected here. And that also cross reaction you get with Spirocerca lupa infection or occasionally with Dirofilaria repens, which occurs in the subcutaneous tissue. So specificity is an issue here. Then quality assurance is also a problem at a manufacturer level. Quality assurance in clinic, because these kits are available. Once you open the packet, then it should be preserved properly. Otherwise, deterioration is quite fast, and then you may get erroneous results. So that is there. And the third and the last factor is variation in the seroconversion. See, there are different types of organism. For example, in case of Ehrlichia canis, it takes around 2 to 3 weeks for the antibodies to appear in the blood circulation. And then, slowly the titer increases. So the detectable level of antibodies have to be there. Then only such tests become positive. So seroconversion, in case of anaplasma platis, it takes around 16 to 20 days. In case of Babesia gibsoni, it takes around 3 weeks. So it takes time, and they again, individual difference is also there. It is not a hard and fast rule. Some dogs may require even a longer period to get the titer against that particular organisms. So seroprevalence is, yes, very handy at one end, but it should be used with caution. Because all these things you should always keep it in your mind when you are using these particular tests. Now, even if the test is negative, now an element of doubt can be created in the mind of a clinician that okay, the dog is showing all the symptoms of CVBD, but this test is showing negative. Could it be early phase of infection where antibodies are not yet formed and not circulated in the blood, and that is why it is showing negative? Or in endemic region, which is more serious problem in India, like as we all know, we are endemic in Ehrlichia, then anaplasma, then hepatozoonosis, Babesia, gibsoni also. So in endemic area, whether these antibodies are as a result of a previous infection, so you are not in a position to differentiate whether the antibodies are, the test is positive, that is denoting the current infection or a past infection. You are not in a position to differentiate between the current infection and past infection, because in endemic area, the exposure is more. And all these tests are based on detection of IgG level, which circulate, the IgG level circulate or IgG circulate in the blood for longer period, for few months. So even, the antibodies that are formed during the previous infection may get detected subsequently after a month or two. So that is the dilemma in the mind of a clinician, how to interpret this. Early infection sometimes is very necessary. For example, Ehrlichia canis, in the early phase, it begins with acute, where there is a bleeding and some symptoms are exhibited. Then it enters into the subclinical phase, which is a prolonged phase extending from few months to even a couple of years, and then it enters into the chronic phase, which is a very, very critical phase. So you have to catch Ehrlichia canis infection at an early stage. But if you are using these tests for detection, and if the antibodies are not formed, then obviously the results are going to be negative, and you are not going to catch the infection during the early phase. And that is a very, very serious disadvantage, because at a later stage the treatment becomes very, very difficult. We have all, usually we say in judiciary system, yeah, that the justice delayed is justice denied. In a similar mode, we can say here, particularly in ehrlichiosis, that the diagnosis denied in early phase is almost, diagnosis delayed in early phase is like a diagnosis denied. So when these tests are positive, then you are in a dilemma. Is the dog really affected? When the test is negative, again, in non-endemic area particularly, then the dilemma is the dog not really infected? So this dilemma is always there with these immunodiagnostic kits. Then coming to the molecular techniques. Now this is a really good, invention as far as the diagnosis is concerned, because the technique is really very, very sensitive technique. DNA is detected. So, the sensitivity may be 1,000 times more than the conventional method. And once the DNA is detected, it denotes the active phase of infection. So the current infection is detected. So that is the advantage of molecular technique. There are different forms of molecular technique. As you can see on the screen, that there is a simple conventional PCR, nested PCR, then PCR, RFLP, multiplex PCR, by which, with one sample, you can differentiate different types of organism. Real-time PCR, which is a somewhat recent invention, in the sense that, you can quantify the DNA. Of course, the quantification also has a role, so as to decide whether the treatment is efficacious or not, or the period of treatment. Of course, in India, we haven't gone that far as far as the research is concerned, where the quantification is helping us in our day-to-day clinical practice. So these tests are sensitive. They are fairly specific. See, there is one myth amongst the pet practitioners, that molecular diagnosis is 100% specific. No, it is not always. There is a chances of cross reactivity, because there are a number of things. What type of template that is being used, what gene is being exploited for this particular technique, then the thermal cycler conditions, annealing temperature, so many variables are involved here. And if all those specifications are not followed scrupulously, then there may be error and you may get a cross reaction. I'll tell you my first hand experience. When we started doing a nested PCR in our laboratory at Bombay Veterinary College, way back, I think in 2006 or 7. And then we were giving these services to the pet practitioners of Mumbai. And then, I found that quite a few samples are turning positive. Then that created a doubt of, created a doubt in my mind that something is going wrong somewhere. How come, all of a sudden so many cases or so many samples are turning positive? So then we did sequencing, and then we found that it was cross-reacting with one of the, organisms, contaminant of the laboratory where we were working, and that organism was a soil bacterium called Granococcus. So that is possible, and that is why, don't take it blindly. If, PCR report is giving positive, and you have your own doubt about it, you challenge it. You can ask the laboratory that please do the sequencing, do the blasting, and tell me whether it is a true positive or a false positive. So false positivity does occur even in molecular diagnosis. The disadvantages of molecular techniques is the non-availability in rural areas, or in two-tier cities, or in small villages, and it is expensive. Everybody cannot afford. As I've said in the introductory remarks of the last lecture, that nowadays even a low-income groups are also having pets. Okay, so with their limited income, they are handling their pets, they're maintaining pets, but the molecular techniques may not be affordable to all the clients, and that is why other alternative methods have to be utilized. So that is the molecular techniques. So these are the three main approaches. Now, when actually I was contemplating on this particular compilation and I was going through the literature, I came across this wonderful sentence in one of the books, that diagnosis is based on clinical signs, biochemical abnormalities, and serological findings supported by PCR. This is the reference. So it is a very, very sound advice, and theoretically, yes, but it may not be always possible, and that is why I have utilized this particular animation. The field veterinarians or the pet practitioners are trying to nail it down, by fixing that particular board, fixing the problem. But how many numbers of nails you hit, ultimately the diagnosis may not be possible in each and every case. One has to keep it in mind always. So, what is a clinical picture, or in CVBD, what actually, rather than me telling you, I think this is the situation you are facing in your day-to-day life, that symptoms are suggestive but not pathognomonic. Pathophysiology, well, now we know that there is a possibility of multiple organ infections. So, pathophysiology may get altered. See, in pathological event, we know the potential of the organism, these organisms can do, but we do not know the way dog is going to respond to this pathology. So there is individual variation. In addition to that, when there is a multiple infection, then there is a lot of the outcome or the expression may change. Some of the weird signs may be seen. So that is the difficulty for the pet practitioners. Then diagnostic limitations, we have seen that if you use conventional method, you can detect certain infections cannot be detected. In immunological techniques, if it is endemic area, differentiation becomes difficult. Molecular techniques may not be available. Sequencing is a tedious job. So even a diagnostic work or a laboratory work may not give you a conclusive outcome. So that is the situation you are facing in your day-to-day life. And then, in such cases, what you do, I know, because I was also a practitioner for 30 years. Then you decide, okay, in my opinion, this is this kind of infection. And then with that presumptive diagnosis in your mind, you go ahead with the treatment. And then you look to the response to the treatment. If the dog is responding to the treatment, then you take it that, okay, my presumptive diagnosis was correct. So you go ahead with the treatment. But let me tell you that, this response to the treatment is also deceptive. Let me tell you how. For example, your prima facie diagnosis is Babesia gibsoni infection. Whatever, you have used certain hematobiochemical parameters on the basis of clinical science. Your diagnosis is Babesia gibsoni, and you use triple drug combination, which also has doxycycline for a period of 10 days or for 14 days. And actually, it is a case of Ehrlichia canis. Okay, so this doxycycline part of that triple drug combination will work on Ehrlichia, and there is a symptomatic relief. The symptoms disappear gradually. Then what, a clinician thinks that, okay, my presumptive diagnosis was Babesia gibsoni. I gave this combination of 3 drugs. The dog is responding. So, he puts it in his record or in his notings that it is a Babesia gibsoni infection. So response to the treatment is also deceptive. Same thing happens with diamynazine. Diamynazine is acting against one or two or three different types of organisms. So you think that it is A, but actually it is B. Diamynazine is acting on A as well as B. Take example of Babesia and trypanosoma. If you think it is a Babesia infection, and in that case, if you give diamynazine, and actually if it is an infection of trypanosoma, it will act on trypanosoma and the dog will show symptomatic relief. So that is how the response to the treatment is deceptive. So don't take it every time. Okay, last time, it had responded, so my diagnosis was correct. And next time, if the case is repeated, I will use the same therapy. Don't do that. You have to start your diagnosis afresh. Then one more thing is that, there is no 100% successful treatment for Babesia gibsoni. There is no effective, in the sense, curable, 100% curable treatment available. Even in Ehrlichia canis also, people say doxycycline is good drug, but complete elimination of the organisms, very difficult, sometimes. Of course, it is difficult to judge also, because in all these infections, unfortunately, there is no protective immunity, right? So you wouldn't know whether it is whether it is a new infection or it is a relapse. That differentiation is really very difficult, and this is a very, very, uh, tricky situation you guys are confronted with in the field conditions. So what should be the approach? Okay, so in such cases, when the dog is presented to you or the case is presented to you, you should go for all investigative. Don't, of course, it all depends on the client also, who is ready to afford, the money also. So wherever it is possible, you do it full hematobiochemical profiles. Then, all possible methods for the specific diagnosis of CVBD, and, record it down. Then treatment, whenever, when you find that, okay, this is the infection which is prevalent in that particular dog and is responsible for the clinical signs, then treat it, and treat it, judiciously, in the sense, that schedule has to be maintained. The dose rate has to be maintained. And unfortunately, in some of these cases, like ehrlichiosis, anaplasmosis, or even in Babesia gibsoni infection, it is the oral treatment. So you just write down the prescription, tell the owner, do it. What is the tendency of a owner? After 3-4 days, when the dogs are clinically okay, 1 or 2 doses are skipped. That is not followed. So, you have to explain it to owners also, that even though there is a symptomatic relief, you will have to continue the treatment for 10 days, 14 days, whatever regime that has been described in the TrueCap. So go as per the TrueCap norms, then go all out with a supportive therapy, and most importantly, control of vectors. The vectors, if you control, because there is no protective immunity, every time the infection can set in. Okay, so there is no immunity that is exerted against these organisms. So control of vector is also very important. Then client education is very important, where you should explain the scenario to the dog owners. In most of the cities or urban areas, the dog owners are quite well educated, well read. You can tell them, that this is a scenario and this is how we are treating it. Okay, so tell them, that there is a possibility of relapse. You may come across of same set of symptoms or little different type of set of symptoms. Tell them the telltale signs, what are the signs they should monitor. And then most importantly, tell them, if they see these kind of symptoms again, bring it back to the clinic immediately. What is the tendency of the pet owner is that, okay, last time same set of symptoms were seen, doctor had prescribed these medicines, let me try these medicines first, and then, if it is not working, I will go to the doctor. Even, educated people, they think in that manner. So tell them that, if the same set of symptoms are there, there is a possibility that the organisms are different. Okay, so immediately that has to be reported. And then, if there is a recurrence, if the symptoms are there, then, you have to start afresh, right? I will tell you with a chart how to do it. But before that, let us see the treatment part, which, you all are anxiously waiting for. So in case of a hepatozone, I have not written the name of, but on the left-hand side in the picture, those organisms are there. And I'm pretty sure now most of you will identify these organisms. And in the first row, it is Hepatozone canis, which is the most common. And the drug of choice for Hepatozone canis is imidocarb. Imidocarb is given at the rate of 5 to 6 milligram per kg body weight, and after every 2 weeks, fortnightly, so twice a month. In PROCAP guidelines, it has been mentioned that you should continue giving this imidocarb till the disappearance of these stages, gametogonous stages from the blood. But I don't agree to this particular recommendation for the reason that the medicine which you are giving, imidocarb, doesn't have action on the gametocytes. Okay, so gametocytes disappear slowly with their own speed, own natural fate. They disappear, not because of the treatment. The treatment is acting on asexual stages which are multiplying in the endothelial cells of visceral organs. So once there is a clinical recovery, maybe after 2 or 3 injections, there is absolutely no need to continue just because the gametocytes are seen in the blood. That is my personal opinion. If you look at the PROCAP guidelines, I had also challenged this with the PROCAP experts also, and I was assured that they will give me the reply back. Okay. Then second is, if sometimes if it doesn't work, of course it has got an academic purpose. That toltrazuril is a drug which is used for poultry coccidiosis, and it also works on Hepatozone canis, because as you all know, Hepatozone is also a coccidian parasite, right? So if the cases are refractory, if the cases are not responding to imidocarb treatment, one can think of toltrazuril. I must confess here that I have never used toltrazuril. I have not seen anybody using toltrazuril. Okay, so toltrazuril is recommended in some of the literature, and it can be given orally. Okay, I don't know whether this formulation, intravenous formulation, here they are recommending intravenous 10 milligram per kg. But to be very frank with you guys, I don't know whether intravenous formulation is available in India. To the best of my knowledge, it is not available. So you can think of using the formulation that is available for the poultry. So for oral medication, the dose rate remains same. But with a caution, I would like to say here that there may be digestive disturbances in dogs when you give toltrazuril. But in my clinical practice, it responds very well to imidocarb. And whenever there was a problem in eliminating the organism, I have also tried diamynazine for this. Then the second is trypanosoma. Now in trypanosoma, the drug of choice is undoubtedly anthracycline or quinapyramine compound. It should be given at the rate of 5 milligram per kg body weight, and it should be given as a subcutaneous injection. And particularly in dogs, dogs are very sensitive to this drug. So whatever total dose is there, you divide it into two and give it at 2 different sites so that the adverse reaction will not be there. And if required, you can repeat it after 3 days. Okay. No, sorry. Anthracycline, it has a prolonged period, so I don't think you require it. But if you're using diamynazine at the rate of 5 milligram per kg body weight, it is to be given deep intramuscularly, and if required, it can be repeated. But as you all know, aware about the side effects of diamynazine, there are idiosyncratic reactions, then nervous signs could be there. So one has to be very careful while using diamynazine. Likewise, in hepatozoonosis also, I forgot to mention, you can use atropine sulfate before giving imidocarb injection, because sometimes, there is an adverse reaction. There could be a nodule formation and cholinergic symptoms may be exhibited. Suramine can also be used for trypanosomosis. Of course, it is off-label use. Even in PROCAP guidelines, it has been mentioned 0.1 to 0.3 grams total, which is diluted adequately in the glucose saline or dextrose saline. There is hypoglycemia, so simultaneously you are treating hypoglycemia also by diluting it in dextrose, and it is given very, very slow intravenously. It has to be taken care that it is properly going into the vein. If it goes into the perivascular region, then there may be even sloughing. It is highly irritant drug, so one has to be very, very careful. But all said and done, I think trypanosoma cases respond very well to antricide treatment or quinapyramine treatment. Then the third one is this is Mycoplasma haemocanis or Haemophilus, where doxycycline works very well at the rate of 10 milligram per kg body weight once a day, and I think 2 weeks are sufficient for elimination of the organisms. Now, this is a chart I have picked up as it is from ProCap guidelines, so there's nothing from my side here. Okay. Now, in this chart, you will find that there are two groups. One is a large pyroplasm, that is Babesia vogeli, which is also occurring in India. And in that case, imidocarb is the drug of choice. The dose rate is 5 to 7 milligram per kg body weight. And the similar precautions have to be taken in case of imidocarb injections. If it is a small pyroplasm, that is Babesia gibsoni, it is a real headache for the pet practitioners. I know, because there are different combinations one can try. But, as I've said, complete elimination is difficult and relapses are quite common. So Parvocone is not available in India. So there are two formulations which are commonly used by the pet practitioners. One is a combination of AA, otavocone and azithromycin. Otavocone is used at the rate of around 52 to 53 milligram per kg for 24 hours. It should be divided into, four times. Okay. Oh, sorry, 3 times. So 13.3, I'm sorry. So 13.3 milligram per kg body weight, 8 hours sleep. That means the total dose becomes almost 40 milligram, not 50, 40 milligram. That is for 10 days. Azithromycin, this is the dose of otavocone. Azithromycin has to be given 10 milligram per kg body weight once a day. And that is how you have to give it for 10 days. Now, whenever you are using otavocone, ensure that you are giving it with food. When you are giving it with food, the bioavailability is more. I would say give it with a fatty food, in the sense lipid food. Put some butter, some kind of oily food, so that the absorption is more. Don't use otavocone with doxycycline. I have seen some of the pet owners or pet practitioners using it in combination. So doxycycline will reduce the absorption of otavocone, right? So don't use it with tetracyclines or doxycycline. Don't use it with metoclopramide, so antiemetic. So these are some of the contraindications. One should follow that. Then there is one more combination called as clindamycin, metronidazole, and doxycycline combination. So that is 50 milligram per kg to be divided into 2 doses. Then metronidazole 30 milligram per kg body weight to be divided into 2, so 15 milligram at a time. And then doxycycline 5 milligram per kg twice a day, so 10 milligram is the total daily dose. And ProCap has not given the exact schedule. I'm very surprised to see that there is no schedule. But what we used to do it is for 10 days, like azithromycin otavocone combination, we used to give it for 10 days. In case of resistance, you can also try using buparvocone and azithromycin combination. That also you can try. Then regarding ehrlichiosis, as on today, the drug of choice is doxycycline, 10 milligram per kg body weight. Then ProCap says, give it for 1 month, that is for 4 weeks. But, most of the books or the references are also saying that the treatment has to go up to 60 days. So pretty prolonged treatment is required. So ProCap guidelines says you do it for 1 month, that is for 4 weeks. And Imidocarb can also be used, but I think doxycycline is much better than imidocarb. Imidocarb is also associated with some side effects. So that is how the treatments I have already mentioned, what drugs can be used and the schedule. Now, I think last couple of plates, the supportive therapy also plays very important role in CVBD because as you all know, there is thrombocytopenia, there is anemia, right? So you should give, the compounds which will improve the thrombocyte synthesis or erythropoiesis also, right? So like B complex, minerals, papyrus extract, then erythropoietin, that all should be given to increase the erythropoiesis and thrombocytopiosis. In addition to that, you should also give a fluid therapy. Supportive therapy also includes fluid therapy, liver tonics, antioxidant, because we all know why there is anemia because of the oxidative stress. So antioxidant in the form of vitamin E can be administered on a regular basis. Then you can also, use non-steroidal anti-inflammatory because, as I've said, in long-standing cases, there is a generalized inflammatory reaction. So that has to be done. In case of emergency, yes, you can think of blood transfusion if the donor dog is available. Then corticosteroids can also be used. Now, generally, what I've seen, the pet practitioners use corticosteroids quite frequently because in order to tackle immune-mediated anemia, corticosteroids are used. But my friendly suggestions to all of you is that don't use corticosteroids in a haste. Use it very, very judiciously because you just monitor hematogram of that particular dog on a regular basis, and if it is deteriorating, if it is reaching the life threatening situation, yes, you can give corticosteroids. But otherwise, corticosteroids, as you all know, they are immunosuppressive, so they make the animal vulnerable to number of infections. And of late, there are quite a few references suggesting that that also interferes with the elimination of the organisms for which the specific therapy is or was given. So corticosteroids should be used in a refractory cases. So what should be the plan? For example, you diagnose, you treat, there is a clinical recovery. So what is your advice to the owner? As I've said, client compliance is very important. So tell owner that relapses are common. So watch for the symptoms. Okay. So let us say that first there are no symptoms. Then what you will tell owners? You will tell owners that once in a month, do hematobiochemical assessment once in a month. So you will see, because you know that immune mediated anemia lasts for a longer period, even after treatment also, it disappears slowly. So, you check that whether the kidneys are normal, whether there is a proteinuria, okay, then serum creatinine and BUN ratio, you monitor all these things. And if it is, if it is manageable, then you don't have to give any other treatment, just give a support. But if you find that the trend is deteriorating, that means PCV level is dropping continuously. After first examination, it was say 30. Then in the second examination, if it is 26, 25, the third examination, it is lowering, then it is an alarming sign. Then what you should do, you should go for diagnosis by means of PCR and conventional. There's no point using immunodiagnostic test here. You will have to use PCR or the conventional, which will tell you the current infection, right? Okay, if it is negative, check for other causes, okay, and give a supportive therapy. If it is positive, then treat, as I mentioned in that ProCap guidelines, you have to do it. If on the other side, if there are relapses or reoccurrence of signs, then employ diagnosis by PCR and conventional. Okay, if it is negative, okay, give a symptomatic and supportive therapy, and then follow this hematobiochemical assessment at a monthly interval. Okay, if it is positive, you are going to treat it with a specific and supportive therapy. So that should be the plan in front of you for the relapses. I'm not saying this is a plan for the initial phase of infection or an initial episode of CVBD, but subsequent episodes of CVBD. So that is how I wanted to tell you about the diagnosis and management of CVBD. The take-home messages, this I have already mentioned you that CVBD is more common than what you think. Number of cases are being reported. Hepatozoonosis, ehrlichiosis, mycoplasmosis. You also add Babesia gibsoni here are endemic in India. Co-infections are common, and that is the biggest headache for the clinicians. The symptoms and laboratory findings are, yes, suggestive of CVBD, but doesn't tell you in all cases the precise reason or the organisms involved in it. Thrombocytopenia should not be equated. What I will do, thrombocyte count less than 50,000, I will think it is ehrlichiosis and I will treat according to that, irrespective of what I get in PCR or a conventional method. But if thrombocyte is somewhere around 1 lakh, it could be in trypanosoma, it could be in babesiosis also. So I will not treat it for ehrlichiosis in a haste. That is what I mean here, that don't equate it. Then preliminary investigation in acute phase of infection. If it is a symptomatic case, try conventional method and narrow it down. Okay, shortlist it. Just rule out trypanosomosis, rule out hepatozoonosis, rule out mycoplasmosis, so that you could then can concentrate on remaining 2 or 3 organisms. So blood smear examination is confirmative, but it is not adequately sensitive. Immunodiagnostic approach, I think I have explained it very nicely that early diagnosis is a problem and cross reactivity is also a problem. And in endemic region, it is a major question whether it is a current infection or a past infection. Molecular diagnosis, yes, is better than the previous two, but it is expensive. And again, molecular diagnosis, don't follow it blindly. What is happening in the field, I know that the sample is collected in anticipation of something else and the result comes altogether different. So in such cases, challenge the laboratory, right? I want sequencing done. If the owner is ready to pay extra 3,000 or 4,000 rupees, go for sequencing and see that it is not a false positive, but it is a true positive. So limited treatment options we have, as you all know, then it is very difficult to assess the treatment because of the cross protection of the drug. One drug is effective partially against other infections also. So prolonged supportive therapy and monitoring is the key, where owners compliance is very important. Pet owners must be informed about the entire situation. Okay, otherwise they will just keep on searching net and find out different reasons for the, or may not be even ready to believe the doctor. So tell them frankly, boss, these are the difficulties, this is the situation we are confronted with. Okay, and authentic data on CVBD has to be generated, where the field veterinarians should come together. There should be some kind of publication for the field veterinarians by the field veterinarian, so that the epidemiology is constructed. And the best thing is to control the vectors. Of course, there are certain infections which are transmitted mechanically, like Babesia gibsoni, or even in trypanosoma once I was consuming rodents and other things. But vector control is the key, and that can cure or that can prevent so many other CVBDs. So these are references, and in the last line, as you can see here, I would like to see your name. That you are getting these cases on a regular basis, but that is not being published. So find some way for publishing the information. It will be, I'll tell you, it will be very, very handy for your fellow veterinarians. Thank you very much, ladies and gentlemen. Thank you.
Thank you, sir. Thank you. Thank you for canine So, sir, as you have already mentioned about some medicines, so just would like to tell our participant veterinarians that where you have mentioned about the doxycycline. So, doxycycline for veterinary use, for the first time, it was Alembic company who tried to register this product. And we the trial was we had done a trial, and trial was very advanced.
Okay.
Yeah. So, please stop sharing.
Okay.
The paper is also available. So we have available the dog this doxycycline is not only containing alone doxycycline, but it is with vitamin C and mannitol. That is in life form. So I would like to share the this paper also. Meanwhile, the participants, those who have joined, they can type the questions also if they have any query. So we can discuss about the queries also. So, paper also.
Okay.
Yeah. This is the paper. Injectable.
No, also I have a oral formulation.
Yes, yes,
Yeah.
we also have the oral formulation in all three SKUs, that is 180, 210.
Yeah, because the treatment regime goes extended up to. Yeah.
With our participants, I would like to add that our cost affordable, where the injectable cost, injection cost is only 284 rupees for.
Okay.
For that is for 14 days, one has to go with the injectable, and then they can move with the oral therapy if once those start taking the different size. So there is a question.
Okay, I can't open the chat box here.
Yeah.
Okay, you can read out. I'll answer.
The question is, can you kindly explain babesiosis? What immune mediated hemolytic due to CVBD?
Okay, so there are two parts. One is the specific therapy for Babesia. My combination of choice is triple drug combination. That is, I will use doxycycline, metronidazole, and clindamycin. Okay, clindamycin 25 milligram per kg body weight twice a day. Then metronidazole 15 milligrams per kg body weight twice a day, and doxycycline 5 milligram per kg body weight twice a day. And that I will go for 10 days. Okay, there are certain references available suggesting that you can go it for 14 days. There are few references suggesting that along with this schedule, you can also use a diamynazine that gives a better efficacy. But if you go as per the PROCAP guidelines, you can use only these three drugs, and if you use it for 10 days, the clinical recovery for first two episodes is fairly good. If that is not available, then azithromycin and otavocone combination can also be used. Diamynazine doesn't act alone. Diamynazine doesn't act on Babesia gibsoni. Babesia vogeli, again, very imidocarb is a drug of choice, but that will not eliminate 10% organisms. You will see Babesia vogeli infection in the body for pretty long time. But I would say, you can ignore Babesia vogeli if the dog is above 6 months of age, because, over a period of time, the infection, if you control the vectors, the infection go away, because the organisms also have their usual lifespan. So just take care of anemia. Now, that was the second part of your question, that how you deal it. See, anemia, ideally, if you go theoretically, I would say use corticosteroid immunosuppression so that, the PCV levels and hemoglobin levels increase. But what we have seen, we have conducted about the research on babesiosis, ehrlichiosis, trypanosomosis, and hepatozomosis. Independently, the research was conducted in Department of Parasitology, and we used to get cases from our hospitals where corticosteroids were used as a supportive therapy to combat the immune mediated anemia. And what we found that that 40% of the animals or the dogs eventually died in a span of 3 to 4 months. And when the owners were asked about the exact reason, kind of different kinds of infection and other things. So maybe prolonged corticosteroid therapy for combating immune-mediated anemia will cause immunosuppression and increase vulnerability to number of infection. The second reason is that corticosteroids also interfere in the elimination of the organism by the specific therapy. So my advice would be, if suppose, PCV level is above 20, 25, you can give hematinics and try to, maintain it to 25 or try to increase it. If hemoglobin percentage is around 7 or 6, try to give hematinics rather than giving corticosteroid. Yeah, if the condition, hematobiochemical profile I'm talking about, is deteriorating, yes, you are compelled to use corticosteroid. So that is how I should go for this hemolytic anemia. Yeah.
Yeah. Thank you, sir. Thank you for giving the reply. So, is there any other question? Yeah, from Swati. The question is, how that was Gisonic on PCR? When will you advise to
Yeah. So see, if the dog is clinically all right, okay, tell the owner that the prima facie diagnosis was Babesia gibsoni. These are the symptoms. Tell the owner categorically that 100% elimination of organism is not possible. So you may come across the relapse. Okay, these are the telltale signs which you should look for. Okay, and in the meantime, once in a month, get the dog, for hematobiochemical profiling, and then use that particular chart for your treatment.
Yeah. So, is there any question? Thank you. Thank you. If any, or is there any email ID?
Yeah. Yeah, my email ID is Mr. Gatne, MRGATNE at yahoo.co.in. On my first slide, email ID was mentioned. Okay, or my number, mobile number 98212 98365. 98212 98365, which is also a WhatsApp number. So you can contact me and you can, put forth your questions. I'll be happy to answer if it is possible. Otherwise, I'll just go through the literature. Because as I've said in the beginning, there are a number of knowledge gaps are there, So I don't claim that I have all the information or the complete information is available in the literature. In a given situation, I will try to help you.
This is the best option to send a
I will always say spot on, because spot on is having a refractory action. See, try to understand. Both are acting differently. Nowadays, you have isoxazoline compounds like, different types of oral tablets are available. But try to understand that the medicine which you administer to the animal goes to the tick when it sucks blood. Okay. Now, there are certain infections like ehrlichiosis, which is transmitted within 3 to 4 hours of attachment, right? So that infection cannot be prevented by the oral medication. Oral medication in the long run will eliminate ticks and ultimately will be helpful even in controlling CVBD. But spot on is the method where, the moment the proboscis are inserted, the ticks are, there is a immediate action on the ticks and the ticks die, and gradually you will find ticks on the body, but those are the dead ticks. So for preventing a tick bite, spot on is the drug of choice. But on a long run, if you want to maintain tick-free environment, then oral medication is also necessary.